I'm going to go ahead and welcome you all and thank you for joining us for this fourth session of our speaker series entitled Facing Serious Illness. This 5-part series hosted by LifePath and the Community Hospice in partnership with the Albany Guardian Society has been an exciting endeavor aimed to help us better understand our emotions as part of life and love. It's hard to believe that we are nearly at the end of the journey. Felicia Segelkin and myself, Felicia from LifePath, and I, Kristen Vivian from the Community Hospice, are your moderators. And I will just briefly go over a couple of housekeeping items. As you've been instructed from the beginning of joining, we will keep you muted. And if you could please keep your camera off, it would be helpful for our connectivity. We do invite you to use the chat. If you're not sure of how to use the chat box, just simply take your cursor and hover along the bottom of the screen. You will see the chat icon come up. You can click on that and a little box will open, and then you can type your message where it says type message here, and that is directed to everyone so that we all in the meeting can see what your chat includes. Our speakers have agreed that if a question comes up that's pertinent to the topic at hand, we will go ahead and try to address it at an appropriate time. Otherwise, we will leave questions and time at the end to answer those questions from the chat box, so don't worry. You should have received with your registration a very handy reference sheet, so if you didn't save that or anything, please go back and participate in that. It is helpful. And this presentation is being recorded today and will be posted and uploaded to the LifePath website for you to listen again or to share with others. And the link should be available probably by the end of the week. The first 3 sessions are already uploaded and there for you to enjoy if you weren't able to join us in person. I will go ahead and turn the mic over to Felicia, who will introduce our speakers. Thanks again for being with us today. We hope you will join us for the last conversation in our series on Tuesday, December 7th, Making Our Way to a Good Death. And Felicia, thanks.
Thank you, Kristen. So our first speaker is Rachel Robinson, who is the program coordinator for Albany Medical Center's Center for Excellence in the Alzheimer's Disease. Rachel graduated from SUNY Oneonta with a Bachelor's of Science in Gerontology Studies, and she also received her Master's of Social Work from SUNY Albany's School of Social Welfare and the Internships in the Aging program. Rachel has worked in skilled nursing facilities, assisted living residences, and is committed to working with older adults and their families, providing them with education and support as needed. Our next speaker is Linda Mertz, who is the coordinator of the Internships in Aging project at UAlbany School of Social Welfare. The Internships in Aging project is one of several model programs in the nation that helps train social workers to work with older adults. Linda comes to this position after many years as a social worker herself and therapist to older adults and their families. When not in her work role, Linda is also a volunteer with the Alzheimer's Association. And last but not least is Dr. George Giokas, who is a physician specializing in the care of patients with serious illness. He completed his undergraduate degree from Tufts University, his medical degree from George Washington University, and completed his internal medicine residency at Albany Medical Center. Dr. Giokas practiced primary care internal medicine for 25 years before focusing on palliative medicine. Dr. Giokas developed the palliative care program of the Community Hospice, St. Peter's Health Partners, and Ellis Medicine. In addition to his clinical responsibilities, he remains active in the education of clinicians and the community on palliative medicine and end of care life. And with that, I will pass it on to our speakers for the presentation today. Thank you.
Thank you. So we have two case studies that we're going to just briefly introduce. We'll actually be discussing the two case studies at the end of the program, but we want to introduce this to spur some thoughts. So if we can, next slide, please. So the first case study is Jen, who's helping her mother, Ida, live in Ida's home. Ida has many medical problems, as you can see: heart failure, diabetes, arthritis, worsening vision and hearing problems, and some gradually declining memory issues, especially short-term memory. Ida has suffered some falls. She gets tired very easily. She's not driving anymore, and she's pretty much homebound. Ida is absolutely adamant that she wants to stay at home and she values her privacy. She's lovingly described as being somewhat stubborn and not accepting of change. Jen, her daughter, is worried about Ida. She's becoming tired, spending a lot of time helping Ida at home and taking her to her various doctor visits. Then the second case is Ted. He's 75, and he suffered a massive stroke at home. He's currently in the intensive care unit. He's unable to talk, and he's on an artificial breathing machine as well as a kidney machine. Prior to having this sudden stroke, which was an unexpected event, Ted was living independently at home. He liked to putter around the house. He did have some chronic medical problems and had a heart attack that he survived years ago. And in retrospect, the family says, you know, he's been slowing down a bit, but he was still driving regularly to Stewart's to have coffee with his buddies and puttered around the house. It's been 2 weeks since Ted's been in the hospital since having that stroke. Unfortunately, he's not regained consciousness. He's minimally responsive. He's still dependent on the breathing and the kidney machines. The doctors are saying that he might come off the breathing machine, but almost certainly, because this was a massive stroke, he'll be bedbound and have significant difficulties thinking and being able to express his thoughts. And even getting to that point will take months of extended care, that he'll continue to need life support. And so he'll need a tracheostomy, which is a tube in his neck to connect him to the breathing machine. He'll need a feeding tube placed in his stomach. And he'll likely be transferred to a specialized facility that will be able to provide that care. Ted has not previously completed a living will or a healthcare proxy, and the wife and children are really at odds as to what to do next. Some say he would want everything done because Ted's a fighter, and others are concerned that Ted wouldn't want to be like this, but also have expressed the discomfort at feeling like they have to, quote, pull the plug. So those are two very difficult cases, but I can tell you, unfortunately, not uncommon cases. We will be returning to them later, but hopefully they'll spur some thoughts in our participants. And Rachel, I'll turn it over to you now.
Thank you, Dr. Giokas. So I want to pose this question to our participants. I can't see the chat, but this is one of those moments where I'd love it if you answered in the chat, what keeps you up at night? What are you most concerned about? What are you scared about when it comes to serious illness? And I'll give participants a little bit of time to answer in the chat. But what are you most concerned about? What are you scared about? If you feel like sharing. And it's okay if no one feels like sharing. Felicia or
We are getting some feedback. I will say, being a burden to others, not having an immediate family.
Yeah.
A mother's inability to take care of herself and making her daughter a full-time caregiver.
Yeah.
Getting ill and not returning to take care of your pets, specifically your dogs.
Yeah.
Not being able to do things for yourself and having to ask for help.
Thank you, Felicia, and thank you everybody for your answers. I appreciate you taking the time to share with us and with the group, and your willingness to share. Those are common answers we all hear, right? We hear being a burden is a big fear. We hear pain, losing a loved one, your loved one not being able to take care of themselves, not feeling like you have close enough people around you for help, your loved one maybe not knowing you at the end of it, right? I want to talk about what happens when we receive some unexpected news about a serious illness. First, I want to talk about things we should probably be mindful of. Do any of these words stand out to us as things we think would happen, maybe without us consciously realizing it, right? Stressed, tired, appetite changes, sleep changes, more irritable. Maybe it's hard to think and hard to process what happens when you get that unexpected news. These are some of the reactions we might have when we receive that news that scares us. And this happens before we even try and process how we feel about that news, right? It's hard to be mindful of these reactions we have when we're emotional, but we don't realize that we're emotional. Okay, now we realize we're emotional. We receive the news, we're recognizing our emotions. What's next? How are we gonna process our emotions? Well, first we have to talk about the emotions that we may be feeling. Some of those emotions might be shock or anger or sadness. We might be feeling grief. We might be feeling overwhelmed, right? It can bring up emotions that we're gonna have to process. I like this tangled ball picture of emotions, right? Because I think it accurately represents how tangled our emotions really are. Often with negative emotions, we can feel all of these different emotions at once, and it can be hard to pull apart what we're feeling and why. So things we have to think about when it comes to our emotions. Are our emotions directed at anyone? And if they are, who are we directing them to? We need to find a good place to direct our emotions. Sometimes we accidentally direct our emotions to the wrong person, right? Has anybody felt really stressed about an upcoming commitment, and without meaning to, we get a little short-tempered, or we snap at a loved one accidentally? I do that, right? How do we find a constructive way to place our emotions? Who's the right person? Who's the right outlet? What is the right outlet? Processing our emotions can bring up other emotions or other memories, right? Or other situations you haven't thought about in a long time. Maybe this sounds familiar. I haven't been this shocked since fill in the blank, right? That memory or that past emotion, that past thing can also bounce around in the back of your head. Now that it's brought it up, now you're stuck thinking about it in addition to your unexpected news, right? Maybe processing the emotional news can bring up emotions, memories, or situations that you can't stop thinking about, right? Maybe it exaggerates that. So maybe this sounds like, I was already scared that mom was getting sick, but I didn't think it was going to be this bad, right? This just makes me feel even worse, right? Maybe it brings up some family dynamics, right? And family dynamics can change based on the information we have, any new information that we get. And it can cause a fundamental shift in those patterns of communication and in those family patterns. And it upsets the family's natural state that existed before and is going to continue to exist after this unexpected news, right? Each family member is going to have their own way of coping. It can bring families together, but it could also pull families apart, right? It creates tension. There's a shift in priorities for every member of that family. Maybe we feel overwhelmed by all of the decisions that we think are ahead of us, right? And there are lots of decisions to be made, whether they're about someone's healthcare or money or understanding the diagnosis that's being given and who's going to be the point person, right? All of these are decisions that have to get made, and this is where we see a lot of conflict. Maybe we feel like we're making our fears a reality, right? So maybe when the situation occurs, our fears that might happen, we're more scared of what could happen than what's actually happening. So we're projecting our fears, right? Whatever it is that we're feeling, we have to find a way to process those emotions. And I will say this until I'm blue in the face to everyone who will ever listen to me ever. We have to process our emotions before we can do anything else. It is really hard to make any decision about care facing a serious illness or anything else when you're emotional. We got to find a way to process it. So how do we process it? There are lots of different ways to process our emotions. I'm going to stick to 2 different types of coping strategies. I'm going to stick to cognitive, so many of the stages of Kubler-Ross's grief cycle, and I'm going to stick to active ways of coping. I'm going to start with cognitive coping strategies. Some of the things we could ask her here could be questions or statements like, she's going to pull through. Is there nothing else we can try? Well, you know, I just heard about this new treatment. Can't we try that? Maybe we should go for another opinion. This doctor can't be the only doctor who treats her, right? Some of these statements could be helpful, right? Going for another opinion, you could learn more about the illness that your loved one is facing. Maybe you'll have the diagnosis confirmed, right? But what about when a new doctor gives you a different diagnosis? Do you think maybe that could be more harmful to how you cope? Do you think maybe that leads to you Googling frantically anything you could learn about this diagnosis and what could possibly happen in the future? For everything that I talk about, for cognitive coping strategies and active coping strategies, it could be helpful or it could be harmful, right? You got to find the things that work for you, right? Maybe it could be enveloped in family dynamics, right? So Kubler-Ross, we see a lot of denial, and in denial, we see a lot of blame, right? It's your fault, one sibling to another, right? Or you weren't taking good care of him and this is how it happened. Or you don't live with her, you don't see what I see. How could you possibly know that this is what needs to be done? You're just exaggerating, right? We create scapegoats, we put blame on other people. We ignore the reality of the diagnosis by pointing to other people. That's denial, you know, but Kubler-Ross is a grief cycle. So we're definitely going to grieve when we get a really serious diagnosis, right? It's hard to put grief into words. Grief can often be described as overwhelmingly sad, or like a black pit or a black hole that you're falling and falling and falling into, right? There's 2 types of grief that I see often in my work with a serious illness. I see anticipatory grief. You're anticipating an end and you're anticipating that loss. And with each loss that you have, you get closer and closer to this big end thing that you're watching loom closer. And that's really scary, right? The other type of grief that I see a lot is ambiguous loss, right? Ambiguous loss, if the disease is going to draw out over time, there's likely lots of little losses that we feel along the way, right? Mom can't speak anymore. Well, that's a loss. It's hard to you're going to lose that conversation with your loved one, right? Or Ida can't cook for herself now, right? Well, she used to make the best Thanksgiving dinner, right? Thanksgiving's coming up. She used to do that. That's a loss that's acutely felt. That's an ambiguous loss that no one talks about. And we grieve those little losses over and over and over again, right? Sometimes we cope actively. So we went cognitive, we talked about denial. Now we're going to talk about active coping strategies. Has anybody poured themselves into work to cope with bad things? I do it sometimes. I don't mean to, but I do it, right? Right? It can be helpful. It can take your mind off of the emotions long enough so that you're not feeling overwhelmed, right? It could be harmful, right? I feel like here's where I picture the ostrich with its head in the sand. If you're avoiding the emotions and the news altogether, you're not based in the reality around you, and that leads to denial and avoidance, right? So ask yourself, will pouring yourself into work be helpful or harmful, right? Hobbies. I feel like this is the one where I think about exercise, because hobbies can be really great and I like to exercise, right? Exercise can be really good for you. It's task-based. You have to focus on what you're doing. Movement is good for your brain. All of these good neurochemicals can make you feel like you're doing something great for yourself. But what if you overdo it because you have control over it, right? Do you hurt yourself accidentally because you're doing too much, because it feels too good to get out of your body and out of your emotions, right? I feel like you could also think about baking here as a hobby, right? Baking can be really fun. It's task-based. You're working with your hands. You focus on the measurements. If you keep baking and you keep baking and you keep baking, and now you've got all these treats out in front of you, are you overeating, right? And is it harmful to your physical health, right? So all of these active hobbies, they can be good or they can be bad, but I would encourage you to find a coping strategy that works best for you, right? Maybe you like to be around friends and family. Being around other people, social interaction can be really helpful. The people you trust, your support system, they're a good source of support during emotional times. That can be really helpful, right? But I want to talk about what happens when you get a serious illness and your coping strategy is to go see another doctor, right? Because you want all of the information you could possibly have. We talked about this a little bit, but I want to expand on it a little bit, right? We get another opinion from a physician, right? Reaffirm thoughts. Maybe this provider you like because they have a better way of speaking to you and your loved one than the other provider you saw. That could be helpful to you. But it could also be harmful, right? Maybe now you're balancing more than one provider for one issue, right? And balancing more than one provider means taking the time to see both providers, and then they're both giving you different information. I mean, Dr. Giokas, you're a provider, right? What do you find happens when people see lots of providers for one issue?
Well, first of all, as you said, there are some benefits to that. But it also can be overwhelming. And as you said, just trying to coordinate the information and make sure everybody's talking with each other is a challenge in today's healthcare environment.
Yeah, thank you. At the end of the day, all of our emotions are valid. All of our emotions are normal, and we need to feel them to be able to do the next step, right? It's hard to learn what you need to do. And you need to be able to make decisions when you're not emotional. So you've processed your emotions. What's next? How do we cope? We take action. We navigate whatever the disease or the serious illness is. So Dr. Giokas, we're going back to you.
So disease navigation, and much of this we covered in the prior session number 3 on advanced care planning. So please, and it's available on the web, you can listen to it, but it's important to try and anticipate as best you can, especially communicating your wishes. Think about Ted's situation, and we'll get back to Ted, but how that could have helped the family. Again, sudden health emergencies, whether that's a car accident or a heart attack, or in Ted's case, a stroke, can occur, and even if they're not a stroke like Ted happened to have, but let's say a heart attack or an infection, your brain's ability to process information is hampered by the non-brain, non-neurologic illness that's occurring in the rest of your body. Everything's connected, and when the other parts of your body are under stress, that affects how well your brain can think. Think about when you've had a flu or a bad cold and you're just not thinking clearly. Now magnify that 100 times if you're in an intensive care unit or with a heart attack or with a serious infection. So the thought of, well, I'll deal with it when it happens, unfortunately, is not something that can occur. Identifying who you trust and want to be the primary person to interact with the healthcare professionals who are taking care of you. In New York State, we call that a healthcare agent. And it's important to understand that in New York State, that is not your emergency contact, it's not your power of attorney, and it's not the person that you sign off as the HIPAA. They may be the same, a person can have multiple roles, but just being your emergency contact or next of kin doesn't automatically make the person who will be speaking for you. And again, we encourage you to listen to session 3. Next slide, please. So this is from the National Institute of Health, and it's part of the references we've provided. The importance of preparing for your doctor visit, and I won't read off each bullet, but especially making a list of concerns and making sure if there's 1 or 2 concerns that are most important to you, you tell that to the doctor or the processing nurse, whomever, at the onset of the visit. I want to make sure we leave time to discuss this. Please make that. Also writing down all of your medicines, including vitamins and supplements. This is from the National Institute of Health. Unfortunately, doctors tend to interrupt, And one study showed that you have about 18 seconds before we're going to interrupt you. So be politely forceful and make sure that you identify at the onset of the visit, this is really top on my list, and I want to make sure we leave time to discuss this. Next slide. Again, from the National Institute of Health, and there's a part of the National Institute of Health called the National Institute of Aging that I would strongly recommend my fellow senior citizens to go to about, again, also consider bringing a family member with you. 2 heads are better than 1. 4 sets of ears are better than 2. And I can tell you that, especially if you hear emotional, shocking information, our mind sort of goes on a little buzz for a little bit. And so having another person there to take on that information is so important. And even if you speak adequate English, if your primary language is another language, request an interpreter. And as a matter of fact, if you can do that ahead of time, letting the physician know, I really would appreciate having an interpreter. Most physician practices, and certainly in the hospital, we have translator services that we need to provide to patients. And many times the discussion is much more rich when it's done in a native tongue through a trained interpreter. It's preferred and actually recommended not to use a family member, to actually use the trained interpreter. Next slide, please. So in the hospital, so we were talking about the outpatient setting before. In the hospital, some things to be prepared for is, number one, your community-based physician or PA or nurse practitioner likely will not be the physician in charge of your care. Several decades ago, a change happened where now there are dedicated full-time hospital-based doctors, nurse practitioners, physician's assistants who will care for you. They will be in communication with your primary care doctor or your outpatient cardiologist or whomever, but it's important to realize you're going to be dealing with somebody you've not met before. And most likely, especially if you're sick enough to be in the hospital, there are going to be multiple physicians and providers, one taking care of the primary problem, likely a hospitalist. You also likely will have a cardiologist or a lung specialist or a neurologist, and they'll be on different shifts. So you're going to be talking to lots of different providers. And unfortunately, though we do our best, conflicting messaging from different doctors from shift to shift is unfortunately common. I apologize for that, but that's just a reality of our current world. Use your patient portal. So most medical practices now, they come by different words, Follow My Health, My Albany Med, etc. But use your patient portal to keep track of the information that's being tracked on you. And unfortunately, this whole COVID situation, unfortunately, has so impacted visitation in hospital-based patients. It is so sad that it's had that impact among the so many other impacts it's had on our society. Next slide, please. This is crucial. Make sure that you can restate in your own words what you're hearing from the doctor. We're actually training physicians and nurses not to just say, do you have any questions to the patient, but asking the patient to restate in their own words what they're hearing from you. And if you can't do that, then honestly, we as medical professionals and nursing professionals have not done a good enough job translating our medical jargon to information that you can hear. So you really should be able to restate the information in your own words. Next line, please. So the golden years for those of us 65 and older sometimes are not as golden, at least physiologically. It certainly holds many, many treasures. But the reality is, after the age of 65, we're going to be dealing with multiple chronic and progressive medical problems. Diabetes, heart disease, COPD are not only ones that co-occur, but unfortunately are progressive. The leading cause of death in older individuals is a result of these chronic illnesses progressing. Again, whether it's heart disease, And cancer in many ways, though unfortunately and tragically, there are cancers that are sudden and present at a very advanced age. Many cancers, because of available therapies, have been transitioned to chronic illnesses. Alzheimer's disease, diabetes. And because we have multiple medical problems, we're increasingly on more and more medications. And here are some statistics that you can see. Rachel talked about how we have to make lots of decisions. And that's part of this. You're going to be living with an illness that you're going to have for years. We want to have as many years and as many good years with that illness. But over time, and especially because these illnesses are progressive, you're going to have to make multiple decisions and re-examine decisions that you've already made. Next slide, please. It's important to understand the difference between life expectancy and lifespan. So life expectancy is the number of years that a person within a certain generation or culture is expected to live once they're born. So currently in the United States, overall, the life expectancy for a woman born today is about 78 years. Life expectancy for a man born today, or a male child born today, is a little bit less, maybe about 74 years. Women live in general, a little bit longer than men. One of the tragic things about COVID, unfortunately, is that if you look at life expectancy, which has been gradually rising over the past several decades, it's actually decreased over the last several years related to the stresses of the COVID epidemic. But lifespan has not changed. So it's not like people are now living 130 and 140 and 150 years. And 300 years ago or 500 years ago, there were still some people who lived to 80, 90, and 100. It's just that that was a smaller proportion of the population. So a larger proportion of our population, thankfully, are living a longer life, but we haven't extended the lifespan of human species. Come 100, even in the most fit, remarkable individuals, 105, or like this person smoking and drinking vodka every day and doing all the things that we've told her she shouldn't do. She's celebrating her 100th birthday. But unfortunately, as she approaches that 100th birthday, she's dealing with multiple medical problems, likely multiple medications, which she may be refusing to take. But her years are numbered because we haven't magically extended the time that human beings live on this earth. Next slide. This is a complicated slide, and I apologize for it, but it talks about the different trajectories. So again, one trajectory that is not on this slide is a sudden fatal illness, whether that's a sudden diagnosis of cancer, an overwhelming cancer at an advanced stage that the person will pass away within just a few weeks or months, or a person who has a sudden massive heart attack and yet was healthy up until then. So that sudden unexpected death, which is the least common. In the United States, only about 10% of people die that death. Though you ask people, that's the death they want to pass away from. They want to have wonderful, excellent quality of life and then suddenly pass away. That's only about 10% of us. So the other general three trajectories are the following. And for each trajectory on the right-hand side of the slide, the vertical axis going up to down is the person's functional status, while the horizontal axis is the amount of time from the time of the person's diagnosis. So the first trajectory is the trajectory that we frequently see with cancer. And in that trajectory, initially, the person's function is very good. You can see a slight gradual decline, and there's probably little bumps back and forth as people have various therapies and complications of illness. But generally, there's a shoulder and then a steep decline, which in general for patients with advanced cancer, the marker that that shoulder is occurring is when the person is spending the majority of their time in a chair or in bed because they're just so tired. When people are that fatigued, that's a marker that the cancer is progressing. And unfortunately, despite the wonderful and multiple medications we have to treat cancer, many cancer treatments cannot be given when a person is so tired that, again, the majority of the day they're spending sitting in a chair or lying down because they just don't have any energy. Many of the cancer treatments actually can't be given because they'll have more side effects when a person's that debilitated. The second trajectory is someone more so with, let's say, heart failure or COPD, which we also call emphysema or chronic breathing problems. So they're limited to some extent by their underlying heart failure or COPD, but they'll go through these phases. You can see sudden dips where they might be hospitalized with heart failure or with what we call an exacerbation of COPD or a pneumonia or something like that. And you'll notice that with each dip, there's a concern, well, will they pass away? That's sort of the bottom of that U that you see, but then they recover. Fortunately, they don't recover to the same level that they were of function prior. Then at some point, they'll have another dip and then another dip. And one of those dips, they're not going to survive. And the challenge with this is it's less predictable. Cancer diagnosis, when we get to that shoulder, as I was talking about above, is more predictable. Heart failure and COPD is much less predictable in terms of amount of time. And then the last trajectory is more the frailty or general dwindling. And this is a little bit like Ida, where she's becoming gradually more frail. She's needing more and more help at home, whether or not she's also cognitively frail. So there are some individuals who are both physically frail and cognitively or intellectually frail due to dementia or multiple strokes, or sometimes they're quite alert and dread. And I can see a number of the comments that were shared about the sense of not wanting to be a burden on other people, the sense of being independent, being so important, and how difficult it is to accept help from others. Next slide, please. So just some general guidelines. Any medical treatment, whether it's a knee replacement or whether to start chemotherapy or whether to go through an ICU admission, can basically be broken down to three sort of spheres. One is, what's the benefit of the treatment? And these are things for you to try and think about as you apply either to yourself or to people that you're asked to help make decisions for. And the importance of the first sphere is that the benefit is defined by you, the patient. Doctors don't define the benefit. The patient, the person, defines what are they hoping the treatment will achieve. Well, I'm hoping if you do a knee replacement that I can do the New York City Marathon next year. Or I'm hoping that if I go through this ICU course or this chemotherapy, that my cancer is going to be gone, or that I'm going to live a full life, or that I can return home and be independent and enjoy my family. You define what the benefit is. The effectiveness of the therapy is really the physician's call. Is this treatment going to work? Well, I can do a knee replacement, but since you haven't been exercising and you have a number of other medical problems, I don't think you're going to be able to do the New York City Marathon. You might be more active, but I don't think you're going to be able to go through the New York City Marathon. Maybe you will, but so again, the effectiveness is, what does your doctor think? And this is where maybe getting another opinion. Is there another treatment that will meet the benefit that I want? That might be a potential role for getting a second opinion, or another opinion as, do we think this is going to work? The burden So those are the three spheres: benefit, effectiveness, and the burden. The burden is something that you and your doctor discuss together. So let's go to the next slide. So there are many burdens of therapy, and as physicians, we can talk about, well, this treatment could cause side effects of affecting your immune system, for example, if it's chemotherapy, or losing your hair if it's chemotherapy. But there's so many other burdens other than just physical burdens. The number of medications you need to take to go through the treatment, and people who are on multiple medications can tell you how difficult it is to keep track of them. Make sure you're not running out of them. Make sure the timing's appropriate, because certain medications shouldn't be taken with food or before meals or after meals, etc. If you're going to go through surgery, you're going to also have to commit to a course of physical or occupational therapy. Surgeons will tell you, if you're going to have your knee replacement, or you're going to have a rotator cuff, or whatever it is, you need to commit to therapy, because the success of that surgery is dependent on the following through with the therapy. And that takes time, and that takes work. Is a treatment available locally? So again, that idea of going to a specialized treatment center, whether it's a cancer center. Fortunately, many of the cancer doctors locally have connections and communication with a number of the cancer centers. And we're fortunate in this part of the country to be, we have Memorial Sloan Kettering in New York City, Dana-Farber in Boston, Roswell Park out in Buffalo. So we're fortunate to be not that far away from some major cancer centers. This takes time. This takes time in terms of doing the treatments, going and following up with the testing. Cancer patients will tell you, well, I have to have my surveillance PET scan every 3 months or so. The impact on your life, your personal commitments, the things that you enjoy in life, the financial responsibilities. We actually have a term for that called financial toxicity, how expensive these things are. And so many of the comments earlier on were the impact on my family. I don't want to be a burden on my family. What's going to happen to the pets that I'm supposed to watch out for? It's really humbling as a physician, quite honestly, that when I'm frequently asked to share bad news with patients, the first thing on their mind that they respond to me is their concern about their impact on their family. It's really a humbling thing to realize the love that people share, sometimes at some of their most difficult moments. Next slide, please.
Dr. Giokas?
Yes?
Just one quick comment with regard, I think, to a couple of the slides you mentioned. We had a question for you to explain frailty and vigor in maybe some of the differences of that quickly with respect to making those choices.
Okay. So frailty is a general term, but in a medical sense, it's can be measured by a person's endurance, ability to do things like, can they take care of themselves? Can they do what we call their own activities of daily living, feed themselves, dress themselves, etc. The more frail you are, the more assistance you need with some of those basic activities of daily living. Are you vigorous enough to shop for yourself, etc.? There is cognitive or intellectual frailty, which may be related to having multiple strokes or various types of dementia, where you intellectually may not be able to do those tasks. But from a frailty standpoint, I'm talking about the physical ability, both endurance, to do those basic things. And we know that the more frail an individual is, that impacts their ability to undergo therapies, whether that's surgery or chemotherapy, etc. Vigor, I'm not sure if it's a medical term, but would be the opposite of frailty, or a vigorous individual would be the opposite of a frail individual. I hope I answered that question. So I recommend this book by Atul Gawande. It was on the New York Times bestseller list several years ago. Talks about the reality of being mortal, especially in our aging population in the United States. And he talks about these questions that we should ask ourselves. And as physicians, we should be talking with patients about what matters most. And some of you already put that in: independence, effect on family. What are you hoping for? What concerns you most? And as Rachel said, over time, you're going to have to be making many decisions because these are progressive illnesses. What trade-offs are you willing to make to balance some of those priorities? Next slide. So I was asked to share a couple of thoughts about palliative care and hospice. Palliative care is a specialty of medicine. It's for people with serious illness. We really focus on quality of life. It's provided by a specially trained group of doctors and nurses and other specialists who work together with your physicians. We're an extra layer of support. We focus, or it's dependent on the patient, it's not dependent on the patient's prognosis, and it can be applied at any age and at any stage of illness. There are palliative care teams at each of the hospitals in the Capital District area, and there are outpatient palliative care teams as well, though primarily most of the teams are inpatient based, but we're developing outpatient palliative care programs. Next line, please. So these phrases of comfort-only care, hospice, and palliative care can be confusing. So I've tried to break them down. And also realize that these can describe services. Excuse me, I'm on a webinar now.
Oh, okay. We have a call in here in 10 minutes.
Sorry, excuse me. There's comfort-only care. I'm sorry, we're trying to reserve a room here. It can be a service of care. So there are hospice services, there are palliative care services. It's also a way of training physicians and skills that physicians and nurses should have. So comfort-only care is generally applied in the hospital where the goal is for the patient to have a comfortable death. And the patient likely only has hours to days to live. The cue as to when comfort-only care is appropriate is a time-based cue. This patient only has hours to days. And their resuscitation status is that they are what we call DNR or DNI. When their heart stops, we're not going to try to shock them or put them on artificial machines. Hospice is a type of care and a philosophy of care. So it's both a service that's available in the community, in hospitals, in nursing homes, in homes. So it's a service, but it's a philosophy of care where the goal is that the patient is going to have the remaining time in comfort. They'll allow certain treatments, meaning the patient and family will allow certain treatments to give them as much time as possible, but also realizing that certain treatments are not going to be helpful at this stage of the illness. Generally, patients have a prognosis of weeks to months. The cue is time. So the way Medicare was set up for hospice is that two physicians, one of them is your primary or cancer doctor or heart doctor, has to say that most likely, it's not a guarantee, but most likely you will pass away within the next 6 months. And the majority of patients who are on hospice, because we're dealing with the terminal illness, are DNR. But it's different than comfort-only care because patients have a longer period of time, and we would continue medicine. So for example, if you have cancer, but you also have heart disease, we're going to continue your heart medications. Or if the primary reason you're on hospice is because of heart disease, we're going to continue those heart medicines that are still giving you adequate time. In terms of palliative care, this is where the goals are curative and life prolongation and quality of life. People have a prognosis of months to years. This is the type of care that's available. The cue is need, and patients can have any resuscitation status. They don't have to be DNR or DNI. So I hope that helps describe some confusing terms. Next slide, please. So Linda or Rachel?
Yep, no, I think that's me. So we're going to return to Jen and her mother, Ida. And you've heard the case before, and I am going to read it again. But just as I'm reading through the case, do you recognize yourself or friends or family in this case? And if there is a part of this case that you would really like us to focus on, go ahead and throw that in the chat as well, because there's lots of issues going on here, and we have a limited amount of time to review them all. So let us know which parts you find most troubling or upsetting, or you feel like you'd like us to try and struggle through a little bit. So Jen is 65. She's helping her mother, Ida, who's 92. They live in Ida's home. Ida has multiple medical conditions, and she's also suffering from a declining memory over the last several years. She's had some falls. She tires easily, no longer drives, and rarely ventures out of the home. But Ida is adamant about living at home. She values her privacy. Her family lovingly describes her as being somewhat stubborn and not accepting of changes. Jen is worried about Ida's safety and is also becoming exhausted, spending more time helping Ida at home and taking her to various doctor visits. So I'm just taking a peek in the chat. I don't see anything there yet. So I'm just gonna like wander through some issues unless you guys are gonna guide me. And I'm gonna encourage.
This is Felicia. I don't mean to jump in, but I didn't know if maybe a conversation around like safety versus staying at home versus another level of care could be a good starting spot.
That is definitely a great place to start. Oftentimes family will worry a lot about an older person's safety in their home. I see that a lot when older people are living by themselves. There's a lot of issues that come up around safety. For one thing, I will hear families say, I need to get my mother to a nursing home or assisted living or whatever because she's not safe at home. So it's hard to figure out, what does safe mean? Does safe mean she's, wandering away in the middle of the night and, walking out without a coat? Well, that is unsafe. Are you worried about her because she might fall? That is a concern, and you maybe want to do some sort of assessment around, I see the chat, great. You may want to do some sort of assessment around how, home safety and like, are there lots of rugs? Is she going to trip? But the God's honest truth is that someone can fall in a nursing home or can fall in an assisted living. People don't, hover around and bubble wrap them and pick them up off the, bounce them off the wall or something. They might fall in a setting as well. Could some of the safety needs be met by assisting a little bit with some services during the day, some other supports, that sort of thing. I see. Oh, okay, more things. So I was saying, will Jen wear out before Ida? That is such a good question because she's getting exhausted. And so some of the things that, worried about Jen, balancing work, time, care needs of a loved one. How could I contribute as a long distance child and not having siblings who are closer, bear all the burden? That's thank you, Kristen.
If I can jump in for a second, there are studies that show that caregivers are at a higher risk of heart attack, stroke, depression, car accidents. So definitely there's an impact physically, emotionally, everything's tied together on caregiving. Absolutely.
And I will say too, that when it comes to caregiving, one of the things that I see most often in my clinic that I have to suggest and facilitate and work with families and caregivers on is recognizing when it's time for a break. And what does a break mean? Recognizing when it's time to bring in respite, and how do we get respite, and how do we facilitate formal services, like actual aides that come in and provide help, versus informal support, as in, is there another sibling around that maybe can help take care of Ida for an hour or two while Jen takes a nap, or while Jen does the food shopping, or while Jen sees friends, right? And recognizing when it's time. And what I want to point out in a situation like this when it comes to caregiving is seeing how these things intersect, right? Seeing how caregiver stress and burden intersects with accessing supports, intersects with recognizing burden, right? All of these things kind of come together, and it requires recognizing it and knowing who to turn to.
There are some great things in the chat, so make sure I'm sure we're not going to get to all of them, but there's some wonderful ideas there. Rachel's just talking about respite, those sort of things. And someone had mentioned in the chat, talking to Ida about what she wants out of living at home. I think talking to Ida also, hopefully maybe not Jen talking to Ida, but someone else talking to Ida about what does she want her relationship with her daughter to be like? Does she want to be remembered as a helpful mother or as a terrible burden? So that might be something that a long distance sibling could do, could be the person to talk to Ida more about making some choices that would maybe preserve her ability to do fun things with Jen instead of always having to, the things that she does with Jen is, she helps her, bathe and get in and out of bed and lugging her around, that maybe she can preserve some fun activities with Jen rather than just stressful caregiving.
Yeah. And to that point, I would say recognizing caregiver strengths, right? If the long distance caregiver is the person who is better with money or is better with organization of certain things, and the caregiver who's closer in distance is better with hands-on care and bringing food and say short distance is Jen, right? If Jen is the person that's closer and is better with short term, let's bring over food and we'll spend 2 hours with the family here and we'll spend an hour with this person here and we'll look into a day program here and you can have friends over here, right? If that person's better with that strength than the long distance caregiver, so say Jen has another sister or a brother out in California and they're better with the paperwork, play to the caregiver strengths and work as a team as best as is possible given the family dynamics.
Some people had raised in the chat too, would Ida be likely to accept help at home since she's kind of stubborn and not too accepting of changes? And yes, that is definitely an issue. People are often not keen on having somebody they don't know coming into the home. As a social worker, I would be thinking a little bit about what is Ida's memory loss like? I mean, at some point, she may just need to be told that these people are coming in. Or maybe there's some way of saying, oh, this is somebody coming in to help me, Jen. They're going to come and help me. They're not here for you. Just ignore them. I invited them in. So because sometimes we have to be a little bit creative in terms of how can we maybe Ida's judgment is not as she may not be able to make the best decisions about whether somebody can come into the home or not. She may not be able to really adequately judge that Jen is really getting worn out.
And we say this a lot in the clinic too. We have to know our person better than we know our disease, right? So if we know Ida and we know Ida likes to embroider, or she used to enjoy arts and crafts in some way. If we have someone coming in as respite to give Jen a break, but Ida doesn't want to accept that person coming into her home, maybe we pitch it differently. Maybe this person is coming in and she decided she wanted to do crafts with you, right? This is something you have all the materials for, you wouldn't have to buy anything and she would spend time with you. That's all it is, right? Find a different way to pitch this person coming in to help.
sometimes there's lots of things in the chat about home health care. Yes, indeed, it is expensive.
Yes, it is.
Definitely look into, there's some programs for folks who have Medicaid, also sometimes churches or other helping groups may be a possibility in terms of helping, as well as adult day programs are a lovely opportunity for somebody to get out of the house if that is possible.
Yeah, highly recommend looking at the resource sheet that Felicia and Kristen sent out when you registered for this program, and highly recommend looking into what's happening in your local area offices for aging, because they may know more about what's available for you.
Yep, somebody
I'd also encourage reaching out for those of you who are internet capable of patient support groups. Sometimes patients and families have found solutions or helps or tips that even we're very accomplished medical and social work professionals don't have. Because you faced immediately with that problem. So reach out to patient support groups, caregiver support groups, and there are some on references, but certainly I admire the resourcefulness of family members taking care of individuals.
One of the things that I know we had spoken with my in-law family about when my father-in-law was very ill was one of the sort of arguments around having someone come into the home was, your choice is have somebody come into the home and help make this work, or we're going to have to, think about living someplace else, like a nursing home. And, although you don't want that to be a threat, it is sometimes that is the choice. That is where we are. So if you really want to try and make this home thing work, there may be some things that are uncomfortable, like having somebody you don't know in the house. But if that's the goal, I want to help you make that happen. You got to help me too. I saw some faith communities as some suggestions for where you might find help. Also, villages. I know the Albany Guardian Society has been working hard on creating communities of people supporting each other. And if you, I don't think that's on our resource sheet, but I'm sure if you Googled it, you might be able to find, there may be some in some of your local areas. What have I missed? There's so much on this chat. I'm sure I've missed a million things. I would just also say, it is okay for Jen to be exhausted. It is really okay. I think usually when I meet caregivers and they say, I think I'm, getting to the end of my rope, usually their end of their rope was really months and months ago. People do amazing things to continue to try and care for their family members. So if, I would very much respect Jen if she's really sort of saying, I'm becoming exhausted. I would take that very seriously. And never feel guilty about that either.
Are we ready to move on to Ted?
I was just going to ask that. I don't know. Anything else? We can always come back if you want to, if as we're talking about Ted, we're like, oh, dang, on case number 1. Yeah, mental health care for Jen would definitely also be a help if she can. Mm-hmm. Yeah, support groups, if there are caregiver support groups. The one beauty thing about COVID is a lot more resources are available online. So you may feel like, oh, I can't leave my house because I'm trying to take care of my mom. Sometimes you can get support groups like this via Zoom, and it's definitely a useful thing.
And I'd like to share a patient story if I could, which is a little bit different than this case study, but also talks about the anticipatory grief that Rachel was addressing. So I was asked to see a daughter who was taking care of her father. It happened to be in her own home. And the father had a terminal condition. I believe it was cancer. And the situation was that the father lived in a downstairs bedroom and the daughter lived upstairs. So he had accepted moving into her house, which may not be something that Ida and Jen could work out. And the daughter had like a baby monitor. So overnight, if there's something happened, she heard a bump or something, that was sort of her safety feature. But what touched me was that she shared that every morning she would go to the downstairs and put her hand on the doorknob that would open the door to her father's bedroom. And she talked about how just putting her hand on that knob to open the door, there was one side of her that was hoping that he would be alive, that they would have another day together. But there was another side that was hoping that he had passed away peacefully overnight. And so that sense of anticipatory grief that Jen might have, including maybe if I came by and I found that mom had passed away at home and appeared that it was a comfortable death. Sometimes caregivers feel guilty about that. They're certainly not wishing that their family member is going to die, but they also realize the toll of this that's taken on themselves and their family members. So Rachel or Linda, could you talk about that sort of sense and the guilt sometimes that occurs?
Absolutely. Absolutely. I can talk about it from a personal standpoint. I mean, prior to my starting as the program coordinator here at the Alzheimer's Center, my grandmother was diagnosed with Alzheimer's disease. I was a student and I knew that I wanted to work with Alzheimer's and older adults. So this was not a completely new realm for me as a budding social worker. But my grandfather called me from the day he placed my grandmother in memory care until the day he finally settled into his independent living apartment. He called me every night, and every night we talked for an hour, and every night he cried and told me how guilty he was that he placed her in memory care and that it wasn't his wife, but that he couldn't do it anymore. He couldn't do the cares for the frailty, the ADL care. He couldn't handle the questions and the waking up at all hours of the night, right? And so he was anticipating her eventually passing on because he absolutely felt like this was not her, and he felt bad that this was not her, and he felt guilty that he was thinking about this isn't her and where is my wife, and I wish she didn't have to go through this, right? And he was also feeling all of those ambiguous losses of losing what it feels like to be a husband, losing his partnership to his wife of 60 years, 62 years, losing the home and all of the furniture that they bought together and the house that they designed together, right? He felt incredibly guilty, and it took him a long time to work through how that felt. And that's okay. It takes as long as it takes for you to feel a little bit more settled in your decision-making process, right? But you feel all of those grief things. That's normal for dealing with a really serious illness like this.
Yep, and as I said, I do feel like many times when we talk to family, I'm awestruck by the things that they have done to care for their family members. So it is, but it's very hard when you make promises to, care till death do us part, and you want to be there for that person, you want to take care of them. It's very hard to say, I can't do this anymore.
Yeah.
But it often really people can't do this anymore. I mean, things like not being able to sleep through the night, having to pick people up off the floor when you yourself are older, you know, having to deal with incontinence issues and continually changing bedding, and, you know, those things that and, you know, an older caregiver is not going to be able to continue to do for a length of time.
Yeah.
Not by themselves.
I appreciate all of the conversation. I am mindful of time.
Yes, we should move on to case 2.
Wonderful.
Do you want to go ahead and switch? There you go. Perfect. So our other case was Ted, age 75, who had been living independently, enjoying puttering around the house, had some medical conditions, diabetes, mild kidney and breathing difficulties, had had a heart attack a few years ago. And maybe he'd been slowing down a bit in the last year, but was still driving, having coffee with friends. But he just suffered a massive stroke. He's in the ICU, unable to communicate, on breathing and kidney machines to keep him alive. And he's been on these machines for 2 weeks. He's minimally awake, dependent on the breathing and kidney machines. The doctors say the chance for recovery is very slim, would take months of extended care. He would need to continue on life support. He would need more invasive medical procedures, artificial feeding, etc., and would need to go to a specialized facility. But Ted did not, he was well and healthy and did not complete a living will or healthcare proxy. His wife and children are torn as to what to do next. Some feel he would want everything done if there's any chance because he's a fighter, and others say he wouldn't want to be like this, but they don't want to pull the plug. So again, I should have said right before I started talking, if there's things you'd like us to talk about here, please feel free to put them in the chat. You guys had wonderful ideas with the last case, so feel free to do so. I'm just going to super quickly say that, you know, the wife would be his next of kin, so she would be the person who would need to make this decision. But it certainly speaks to a good family life that the group would like to make some sort of consensus decision. And I think it is really important that people that it is a group decision, and it isn't one person making a choice that will then create a rift in the family later on. And I think that, you know, a great place to start would be to find a social worker and utilize that person to get all the family together and to really talk about some of the things that they're thinking about, you know, perhaps the feelings, the guilt, the you know, anxiety around, you know, what will happen with this choice, what will happen with that choice. So that you can get a little bit more sense on where everybody is. That if Ted is in a hospital, there should be the ICU social worker somewhere in there. Find that person and see if you can all get together. That would be my first thought.
And my second thought off of your first, as it relates to wife being the person who would probably make the decision, but admiring that there seems to be some sort of family conversation happening here, is to think about as a family, right? We need to do what's best for Ted, right? This is not about what I think is right. This is not about what you think is right. This is not about what we should do. It's about Ted, right? And since we don't have anything written down about Ted, what do we know about him as a person? Who is Ted? What does he like? What does he value? And think about what he would value in this situation.
You know, there was a comment in the chat about, oops, my computer's doing something, about right to die. And I'm not as familiar with that. So I was wondering if maybe Dr. Giokas has some thoughts about the right to die.
Yes, sorry, taking some time. So I'm not sure if that phrase applies to Actually, there's legislation in about a sixth of the country now in terms of, it goes by different terms, physician-assisted death, physician-assisted suicide. That's not, again, I'm not sure I'm responding to the exact meaning of that question, but that's usually, at least in those states that allow it. In New York State is not currently a state that allows that specifically, and it's almost always done not in the hospital. It's an outpatient where a physician will prescribe a medication with the specific intent for a patient who is terminally ill. And the specific intent is to end that patient's life. The patient has to take the medication themselves. So not only Ted is not in this situation because he can't take the medication himself. So in the states that allow this, where this is legal, the physician can prescribe a medication with the sole intent of the patient taking the medication so that their life will come to an end. Again, not legal in currently in New York State. I would emphasize what Rachel and Linda said, is that though these are clearly decisions that impact the family, from an ethical and legal standpoint, our obligation both as family members or surrogate decision makers, and honestly as medical staff caring for the patient, is what would the patient have said. Ethicists and legal scholars will talk about a term called substituted judgment, which is our first priority, and that term refers to Ted has specifically said, either if I was in this situation, this is what I would want, or may have said something in a very clear and convincing manner, maybe talking about another family member or a friend, where there's no doubt this is what Ted would want. And so what family members are basically doing are Ted's words. That's the term of substituted judgment. The other term is best interest, which is if we don't have those situations where we can say, well, Ted definitely said this, then family members and surrogate decision makers, knowing what's most important to the patient, what makes life worth living for that person, what they would want, what's in their best interest. And that's frequently the situation we're called upon. And as Rachel and Linda said, this affects families because these are decisions that families have to live with. That's why, and I'm sorry it's a plug, but that's why I encourage you to share with your family members, and we're having Thanksgiving and other holidays coming up where hopefully even with COVID guidelines we'll be together, to share with your families what's most important to your life, what makes life worth living. So important, because believe me, that's not only a help to you, it's a help to your family members if they get called on in this situation.
Yeah, I love that thought, Dr. Giokas. Thank you for recommending people talk about this. And I would also recognize for those who are maybe anxious to have that conversation or scared to approach that conversation or don't feel comfortable with that conversation, to remember that it could bring up tension, right? It could bring up uncomfortable feelings. Emotions can run really high. It can remind you of other times you've grieved other losses or other situations where you've had to do this, and it's okay for it to bring that up, but that doesn't mean that we don't recommend talking about it.
And I think, you know, this is still 2 weeks is not a lot of time. And unfortunately, you know, medical decisions do need to be made with, you know, that kind of, you know, I imagine he has a stroke. So the first couple of days you're hoping that he's, you know, coming back to you. And, you know, then the hopes start to sort of dim. But, you know, our natural response is wanting to hold on to someone that we love. We want them to stay with us. We want them to be with us. And I think that's, you know, it may be, it may mean that you need to have another discussion with the doctors and have somebody really walk you through what is the likelihood, what does this look like, what would that be like. I know in my again, my in-laws, when my father-in-law was very ill, he was 92 and did not have a living will or a healthcare proxy, and he was a physician. He wanted people's consensus around DNR. He did not have a DNR. My brother-in-law, who is also a physician, explained, if someone came to him in the nursing home and he had, he was not breathing, they would still need to call a code and, force his chest and break his ribs. And, does he want that? Or is it time to, is the rest of the medical conditions enough that it's time to let him go peacefully? Anyway, I think remembering that you want to help. Oh, go ahead.
I saw a chat just pop up about withholding an intervention, and is that the same or different than pulling the plug? And I apologize for using that phrase, but I know it's an emotional phrase, and that's something that people feel. From the ethical and legal standpoint, there is no difference between not starting a treatment and stopping a treatment. Believe me, it feels different. It feels like we're stopping something, we're pulling the plug. But from a medical, legal, and ethical standpoint, there's no difference between if the patient is not going to benefit, or if the treatment is not going to, again, going back to that benefit, effectiveness, burden scenario, or a way of looking at things. If the person's not going to benefit from it, don't start it. And if you've started it, but it's not working, there's no difference in stopping it. And most major religions, there are a few that will say that there is a special value of continuing once you start, but most major religions also support there's no difference between deciding not to start it or once you've started it, stopping it.
I also saw a question I want to make sure that we address before we finish, which is the specialized facility a nursing home or someplace else? Is this place covered by medical insurance? So in the case of Ted, I know there are some skilled nursing facilities, and a nursing home is the same thing as a skilled nursing facility. The term can be used interchangeably. They do have units specialized with nurses trained to work on the feeding tubes and the tracheostomy. We called them trach supports, the tracheostomies. There are special facilities and nurses that are trained to do that. Otherwise, I don't know, Dr. Giokas, what other specialized facilities there are. And we all know nursing homes are a combination of financial decisions to be covered. So sorry, Dr. Giokas, any other?
Yes, so in terms of place and financial impact is you're right, a huge other issue. But in terms of place, most nursing homes can take care of patients who have feeding tubes, but simply having a trach, that plug that's in your neck to allow the person to breathe, assuming, and this is very important, they're not on the breathing machine, but they're able to breathe, but they need the trach. Only some nursing homes can do that in this community. Many nursing homes cannot. However, if the patient is still dependent on a ventilator, there are very few facilities. There's one locally here in the Niskayuna area. Sunnyview can take care of patients, but it's not a long-term facility. It's specifically a rehab facility. So in most cases, those are called LTACs, or long-term acute care facilities. And unfortunately, one of the closest ones is in Western Massachusetts, and another one is in downstate. So many times families are quite a distance separated from individuals who are still dependent on an artificial breathing machine.
Thank you.
So I'm going to jump in and do a quick wrap up. Thank you so much to our speakers. Our time is dwindling down, and this has been a really wonderful, thought-provoking session. So thank you, speakers, and thank you to everyone who contributed to the chat. We really appreciate the input, which has gotten everyone to really start to think about what impacts our lives when facing a serious illness and some of the solutions that might be available to us, some of the challenges, the emotions, how we can deal with those. And so we're grateful to everybody for your participation today. Just want to again remind you that both the resource sheet and the recording of this session will be available on LifePath website within the next several days. The other 3 sessions are already there, and we hope that you will consider joining us for our final session in this series on Tuesday. Things we're certain of in this life. One is to be born and the other is to die. And so it's a good thing to talk about it and to, as we say, through all of these, to make our wishes known so that we can both live and die as best as possible as people in the way that we would choose. So thank you again, speakers. We appreciate your time. Thanks for everybody for joining. Have a great rest of the day.